Okay, hello and welcome to Virtua Health's RealTalk Women's Health Chat. My name is Nicole Mahalik, and I do afternoons on 92.5 XTU, and I'm thrilled to be your host for tonight's event. It's a special one. Obviously, we're going to be multitasking because I know a lot of you are going to be checking the Philly score. Let's jump into it. I'm so pleased to introduce two experts for tonight's session, both board-certified obstetrician gynecologists who are focused on and specialize in minimally invasive gynecological surgery. First, we have Dr. Minda Green and Dr. Jeffrey Bowers. Dr. Green is a board-certified obstetrician gynecologist and is the lead medical director of Virtua's minimally invasive gynecological surgery. She received her medical degree and completed a fellowship in gynecological surgery at Drexel University. That's where I went. Go Dragons. I'm not a doctor though, but still went to Drexel. And Dr. Green enjoys spending time with her husband, her two sons, their various sporting events, as well as traveling, dining, and listening to live music. Same. Dr. Bowers is a board-certified obstetrician gynecologist and co-chair for robotic surgery at Virtua. He received his medical degree and completed his residency at Thomas Jefferson University Hospital and is one of the region's leading physicians for single incision hysterectomy procedures. In his spare time, Dr. Bowers enjoys being with his wife and their three children and their busy schedule of activities and spending summers at the Jersey Shore. What a treat. Welcome, everyone. Thank you so much for being here. Hello, hello.
Good evening.
Whoa. I love doing these because I love talking to smart people. And when I get to talk to smart people, it makes me happy. Not that I'm not smart, but you're doctors. It's a way different smart. Okay, so let's jump into it. So we covered a lot of ground in these sessions talking about menopause and sexual wellness and saggy pelvic floors and some common questions that many women, unfortunately, they find too embarrassed. A lot of women are afraid to talk to their friends or their loved ones or especially their doctors. So that's why it's been so great to do these. And they're even nervous to talk to their OBGYNs. And so tonight we're going to talk about symptoms and conditions that women often endure alone for years, like heavy bleeding, excessive cramping, or pain during sex or going to the bathroom. We want to know what treatments are available. And as usual, we're going to have time at the end for a Q&A, and people can submit questions in the chat. And so when we get started, we're going to jump into make it kind of general. We're going to talk about some of the most common symptoms that women face, and they might be ignoring them. And this could indicate that something that's really need to be addressed. And then the question is like, and the why, right? If they're experiencing it, then why? And so women endure years of these symptoms before doing anything about it. So Dr. Green, why is that? Why do they just deal with these symptoms and never ask for help?
Well, probably one of the more common reasons is that they don't feel comfortable talking about it, or they might not have a relationship with their providers, or maybe it's not even, quite frankly, asked, right? So sometimes people, if they're not probed with some of these topics that are a little bit more taboo, especially that comes to women's health, they're not going to be forthright in their information. So I think part of the responsibility of us as providers is to ask the questions, right? And sort of hopefully bring those conversations out in our discussions.
Yeah, that's such a good point, because a lot of times people are like, oh, this must be normal. And their doctor's like, are you good? And they're like, yeah, I'm good. And sometimes you do have to ask more probing questions to kind of like coax it out of people. And, for example, I think common myths around what's normal and what isn't. So sex shouldn't be painful. That's not normal, correct?
Not at all, right? Outside of it being its goal of procreating, it should be pleasurable, right? But there are many things that impact sexual activity, everything from our emotional health, our physical health, and then things that have, transpired in our life medically, whether it's the birth of a child or surgery or radiation or having something as simple as a car accident. We don't think that other things that happen in our lives are interrelated, but absolutely all these aspects play a role in any of these symptoms, whether it's related to pain or discomfort or discharge or bleeding. All of these things often have a multidisciplinary, approach to them, meaning it might not just be one single thing. And maybe it is one single thing, but I think it starts with patients feeling comfortable enough and then providers also bring those things that maybe patients don't feel so comfortable about discussing during the visits.
Yeah.
Being
And
scared to speak up.
right. And honestly, it can be a range of things. Psychological, like you just said, emotional fears of discomfort, sign of pregnancy, menopause, endometriosis. And I think kind of what we talked about too was that women feel like it's normal or period pain is normal. And from personal experience, my best friend suffered from horrible periods her whole life and was just told, like, oh, this is what you have to do. Well, come to find out, 6 months ago, she found out she has endometriosis and it was never talked about for her all through college, all through her 20s. She just thought that she had these horrible periods because it just feels like endometriosis is something that it's just starting to kind of come to the limelight and people are making it, and these women have been suffering in pain for years because of it and they just were afraid to bring it up. I'm sure you've both have seen that.
Totally. Totally. I mean, they suffer in silence, right? And so, um, many women have to go through many doctors before they even listen. And to be quite honest, there's not a smoking gun all the time, right? So sometimes the symptoms, can be affected by multiple organ systems. And so we have to, you know, first of all, talk, listen, do focused exams, and then sort of do a system-based evaluation process, because it can be, more than one thing, and certainly different body systems can have very non-specific symptoms. And so we have to sort of tailor our evaluation and our treatment plan to those things.
Yeah. Because not only endometriosis, but ovarian cyst, problem with your pelvic floor. There's also infection or uterine fibroid. So there's so many things. So Dr. Bowers, when should someone be having the conversation with their doctor?
Well, I think that dovetails really nicely in what you already said, right? So I think my experience as Dr. Green has been that many, many women have a tendency either themselves to normalize things that aren't normal, or have been told by family members, friends, other women, other physicians that no, that's normal. Like, you can add on to that list. It's very normal to leak urine when you cough or sneeze. It's not. It's normal to have heavy, horrendous periods as you get closer to menopause. Sometimes it's normal to have a change in your periods, but really heavy, really disastrous periods are not normal. So my general thought process is, if it's bothering you, if it's interfering with your life, if something about it is telling you this doesn't feel right, you should always start that conversation. The other thing you should feel empowered to do is, if something doesn't feel right, if you're missing work because of your periods, if you don't enjoy having sex with your partner, if you're leaking urine so you can't run, can't play on the trampoline with your kids, and someone tells you this is normal, seek a second opinion. That's often sometimes very hard. Oftentimes women have relationships with their providers that extend from their first pastor all through their kids to later in life. And to think to yourself, well, I've known this person for 20 years and this is bothering me, but she's telling me that it's okay. Well, I guess it's probably okay. This is a hard thing.
Mhm.
But if it's getting to the point where it's interfering with those things, you should always, always feel empowered to say, you know what, this doesn't feel normal to me. It's been going on for such a long time. What can we do? What tests can we do? What evaluation can we do? Per Dr. Green's point, can we find a smoking gun? Sometimes it's hard, but it's not impossible. There's a lot of things that your provider can order and test for you to determine whether there's something that we can intervene on to improve that aspect of your life that's not normal.
Right. And like, there's a lot of different things, like both of you said, there could be rooted in so many different causes, right? So whatever that is, to ask the questions. And I think one of the best things about doing these events and doing these virtual events is talking about how you have to be your own best advocate, and that if, even though you are told, oh, it's normal. And, sometimes it's kind of funny, like it's like a hairdresser. You've been going to the same hairstylist for years and you don't want to break up with them, but you don't like your hair, but you feel bad. It's like the same thing with the doctor, right? Like you said, they could have delivered your child. Now your child's 15 and you're a little bit older and you're like, I just feel like I have more answers. You have to care about yourself enough to go ask for the second opinion, to make sure that you're asking the questions, to take any precaution that you absolutely can, because there could be so many reasons for why things are happening.
And
So
sometimes, as Dr. Bauer said, sometimes we have to go through multiple channels, if you will. And I even offer patients myself, if they see me, I said, look, you're always welcome. Like, we are tied to each other as a provider and a patient, even other patients. You are entitled. It is your right to go see what somebody else says, right?
Yeah.
And I think women have to advocate for themselves. This is the time in life as women are caretakers and often put themselves, when they have children and families, to the back burner. This is the time to be selfish. And one of the phrases that I like to use, as Dr. Bowers talked about, the quality of life is really when it becomes a problem, right? So if it's affecting your relationships, your work life, your children, your intimacy, all of these things are sort of very core things in our lives. And when it starts to have a negative impact on them, then we should try and do something about it. But a phrase that I use is, if it's persistent and recurrent, right? Sometimes we have these things that might happen once or twice and we don't really have an answer, but when it starts to become a pattern, right? Putting on diapers at night with periods, and having to wear a pad all the time. I said, well, why do you wear a pad? So some of these things, really bringing it to the limelight and really getting to the bottom of symptomatology, and then we can really focus our evaluation process on that.
Yeah. So both of you are OBGYN trained and specialize in minimally invasive gynecological surgery. So what is that exactly? And would I go to you right away if I start with my gynecologist first and I'm experiencing these symptoms? Dr. Bowers, if you want.
It's an interesting, yeah, it's an interesting landscape. I think our field is changing. And I think it's changing for the better. And I think that Dr. Green and I, where we are, we're in a pretty unique position. We're in an area that has a large number of providers. But what we're finding is that for these specific conditions for which surgery is an answer, a lot of times that's when our colleagues are turning to us. There's so much involved in the training of an obstetrician gynecologist, ranging from, care you provide to women almost like a family medicine provider, where you're doing an annual exam, making sure that just general health and preventative care is taken care of. You're also delivering babies and taking care of pregnancies, and you're also doing surgery. The problem is, as the surgical techniques have gotten more and more sophisticated, it's hard to keep up with that and do everything else. So the short answer, I would say, is that, if it's a problem, that the answer might be something surgical. That's why it's in the name of what we do, right? So the interventions that we do are designed to be operations that even 5-10 years ago would require a long hospital stay and a big incision in your belly. We can do a lot of these things with no incisions or tiny incisions, and you go home the same day. And I think that the landscape is now that a lot of our colleagues are realizing that there's so much to do and so much to offer women that we have to compartmentalize ourselves in a way that this is something that Dr. Green and I and many of our colleagues really specialize in, and really want to make sure that we give the best opportunity to all women to have that aspect of that care, that surgical aspect of their care, be the best it can possibly be.
Yeah. So to provide clarification, does it depend, or do you always first start with your GYN to evaluate and then get referred to surgery?
Well, I don't think there's a straight answer. It's probably all of those things, right? It kind of depends on the situation. I mean, there are times where people through forums like this will be connected to us, right? Because they know that they have a problem. They know that they have fibroids, right? They've had a conversation, even if it was 2, 5, or 10 years ago, and now they know they want to pursue the surgical route, and here we are, they end up to us. But oftentimes it is a referral system, right? Because we may not necessarily be the first line of someone that the patient may see. So it's probably a little bit of all of that. And as was mentioned, so, as surgical fields have embraced minimally invasive surgery, it's really doing, more complex things with a better result, right? So things like hospital stays, as Dr. Bowers mentioned, blood loss, infection, all sort of the complications of surgery. And then on the flip side, having that patient get back to, their normal life and activity quicker. So it's a benefit, that requires some advanced training for people that do this, more frequently. There are some fellowships out there, and then there are other folks that are just driven enough that they have, embraced as the technology continues to advance. And it's like anything else, it advances very quickly. And so there's been a huge swing in the last 10 years, whereas, we all are traditionally trained as OBGYNs in all these varied areas, but we really want to create a niche to be able to provide these, innovative options for patients. And maybe, someone that doesn't specialize may not get all the options, right? Or maybe they get that, that open option, the traditional surgery, which is, there are places for it, but many women with these conditions can be managed with that minimally invasive approach.
It is important. That's a really good reminder for people that science moves so quick and there's so much research and there's so much innovation. And just because you were told something even 5 years ago, even 2 years ago, there could be new procedures, new medicines in place to help you. So that's why it's so important to like keep checking in with your doctor year over year to tell them what's going on, because what you two do especially is constantly are like learning and innovating and coming up with new ways to make these procedures and these diagnoses easier on the patient. So I think it's important for the patient to know to constantly talk to your doctors, because science moves at such a rapid pace and the whole goal is to make it easier on the patient.
Absolutely.
Yeah.
Yeah. And I would say even further than that, like even if you were told on Monday that your surgery needs to have a big open incision, you might be able to find out on Tuesday that it doesn't. Yeah. So as fast as this stuff moves and as advanced as the technology is, I know Dr. Green has had this experience as well, that often we will get consults, and the consults are patients who arrive to our office and tell us, look, I was told by so-and-so physician that there was absolutely no way I could have this done without a big incision. And the perspective that's coming from is not an unkind or unjust one. It's one of lack of realization that there probably is somebody out there that can do it that way, and you just don't know who they are. Mm-hmm. And that's not just two of us. Each region are going to have physicians like the two of us who are really specialized, and this is really what we're passionate about. And this is why this type of forum is great, because we can kind of evangelize this and say, listen, if someone tells you that you have to stay in the hospital for 3 days, or you have to get a big incision, there's some small chances that they could be correct, but they're getting smaller and smaller as training and technology improve. So that's a situation definitely where you say, you know what, I'm going to look and see if I can find someone that does this, and see if I can make an appointment.
Yeah, absolutely. So talk about some of the most common issues that you both see and how you go about coming up with the right treatment plan. So what types of surgeries that include, and kind of start from there. I mean, there's hysterostopic. Am I saying that right? Surgery.
Hysteroscopy.
Yeah, hysteroscopy. So I'm curious of what the most common is, and then some other examples that you both see. And one of you can kick it off, whoever wants to start.
It's men. Well, like we mentioned, traditional surgery is a larger incision. So the most common surgery for women is actually a cesarean section, right? So that's a big bikini cut incision, whether that's horizontal all the way across, or other surgeries where people do a vertical incision, like from your belly button or even above and down. Those are sort of surgeries.
I'm like, what's the technology for the cesarean section? Is the baby going to come out through the belly button at some point?
Well, that we probably can't change, because they are
some kind of weird AI technology where like the stomach like moves itself from like the body or something, some crazy.
If we could, but that's like the traditional abdominal surgery, right? And we're gynecologists, so we operate in the pelvis. So we're talking about abdominal and pelvic structures, right? The uterus, fallopian tubes, and ovaries, and the muscles of the pelvis. And so anything that talks about looking at them, evaluate them. So you mentioned hysteroscopy. That's a procedure where anything that has the word oscopy just means light. We stick a camera, and it's about the size of a pencil.
Oh,
and
we're able to means anything with.
Yes.
Fun. I didn't realize it meant with light. I mean, now that I'm thinking about it, optic, like light.
Colonoscopy, hysteroscopy. We do hysteroscopy and laparoscopy. Laparoscopy is putting a camera inside your belly. But we're able to look from both views, right? So we can do things in the vagina, through the uterus, and then of course all the other abdominal pelvic structures through the abdomen. So the traditional abdominal surgery is if you can conceptualize, is a C-section incision, right? So the bigger the cut, the more pain, the more bleeding, the longer the recovery. And so, as Dr. Bowers mentioned, the things that we remove or we fix or we take care of, whether it's the uterus, fallopian tubes, or ovaries, and masses and structures related to that, can often be done through what people call keyhole or small incisions, right? Our cameras are about the size of a pen. And so the incisions are the width of your finger across. So we're not talking about that 15 centimeter, bikini cut C-section incision. We're talking about smaller incisions. And so that technology, as we mentioned, the Phillies game, I'm a boy mom, so we have sports on in the house all the time. It's like looking at the television today than those of us who are a little bit older, 20, 30 years ago. That's what we're able to use and take advantage of surgically. And so, that's sort of an overarching view.
Yeah, I think it's really fascinating too, because from a person who works on the radio and does nothing in medicine, although I do watch a lot of Grey's Anatomy still. So sometimes I do feel like I'm a TV surgeon. But it's fascinating, right? Because you go to med school and you learn about the body and the anatomy, and you think like you're working on cadavers and you're working on the body. But then there's this whole part of you that like is working with robots and this whole like technology part of it, which makes it even more fascinating. So it's like you're doing things in the body with all this robotic technology, but like that's the beauty of the future, right? Is that it's the beauty of science that like you kind of get to marry these two together to make it easier on the human. So, Dr. Bowers, can you address the uterine fibroids and then discuss sonata? I don't know what that means, so you're gonna have to talk about it.
Dr. Green had mentioned that the most common major surgery performed on women in the United States is C-section. The second most commonly performed surgery on women in America is actually hysterectomy.
Makes sense, yeah.
Hysterectomy is extraordinarily common when we talk about major surgery. There's a lot of minor procedures that people undergo, but major surgery, hysterectomy is still number 2. And the reason is there are still conditions that we have a hard time treating any other way other than removing the uterus. Fibroids being a really big one of them. Typically, women pursue a hysterectomy for things, non-cancerous things like heavy bleeding or pelvic pain or pelvic pressure, and fibroids are a culprit in almost all of those conditions. Now, what's interesting now, and this really is over the last 5 years or so, is we've actually started to develop several newer techniques, one of which is Sonata, one of which is Acessa, that allow us to treat fibroids very effectively without performing a hysterectomy. Up until those 2 procedures came out, really we had 2 options. 3 if you count treating them medically, which has some limitations. But as far as surgical options are concerned, we could go in, we could remove the fibroids, and we could put the uterus back together. Now, fortunately, now we can do that robotically or laparoscopically, still give someone a rapid recovery, but it does involve cutting into the uterus and actually displacing some tissue from it. The second option that we had previously was hysterectomy, was removing the uterus. Now what we have are either through the cervix using ultrasound or through one of those keyhole incisions, delivering energy to the fibroids that causes them to shrink, causes the symptoms that are caused by them to abate, sometimes in quick as 1 period, but certainly by 6 months, many people have significant relief. And this is something that both Dr. Green and I do. And it's something that very few areas are able to offer some of these alternative treatments. That's thankfully changing as training gets more improved, but it's another reason why women, as they seek care, in particular for fibroids, should advocate for themselves and ask, what else is out there? You're telling me I need to have my uterus out, or you're telling me I need to have my fibroids removed and have a longer recovery. Is there anything else there? And the fact of the matter is, truly, now there are. And recovery from those procedures are as little as 3 days. So it's kind of an incredible aspect of care that we can offer to that particular condition that's so common. There are estimates that 40 to 70% of women have fibroids. Not all of them have symptoms, but 40 to 70% of them have them. Yeah, it's a huge number, and it's a huge impact on women's lives.
Here's a question that I don't know if anybody has asked, but I'm going to ask it. What is the difference between, you hear a lot about cysts and ovarian cyst, but then you hear of fibroids. So what is the difference between fibroids and a cyst?
Yeah, so
Very
fibroids
different. So
yeah, go ahead.
no, please. I think we're going along the same lines. You
Yeah, yeah.
start.
Fibroids are tumors, right? If you look it up, it's considered a tumor, meaning it's a solid mass, right? So fibroids, by definition, with being a solid mass, are not going to disappear, right? So it's not something that's going to go away, right? As Dr. Bowers mentioned, a large majority of us at some point will have fibroids in our life. However, most of us won't have a surgery, but obviously we see all the women that have problems related to this. Cysts have fluid in them, right? To some degree. Cysts can be solid as well, and those are usually a little bit more concerning because solid things, again, don't disappear, they don't dissolve. But fluid does resorb and resolve often. And as it pertains to the ovary, which is the most common area where we're going to deal with the cyst, most of them will actually resolve, and we don't have to operate on most of those.
Yeah, you hear a lot of women talking about how their cysts burst.
Yes. And so again, as we go back to that initial motto of when it starts to become a persistent problem, or those of us that do this all the time, right? We obviously have women who have very large cysts, so we know that related to size. So there's something the size of an orange or a cantaloupe or a melon. Those are a little bit different than the size of a pea or a grape. And women who are menstruating and cycling do make cysts on a regular basis. We're just not getting imaging to prove it. And often, it ebbs and flows, right? Most of those cysts will resolve on their own. And certainly the ones that don't resolve on their own, cysts that people might have heard of called dermoid cysts or something called an endometrioma. Those are related to endometriosis, sort of a collection of those cells in the ovary. Those are the types of cysts that won't self-resolve often. And so, related to size and symptoms is where we make a decision. Do we try and manage medically? Do we follow them expectantly, meaning we just do some watchful waiting, or do we need to do something surgical?
And do we know what causes cysts and fibroids?
It's a good question.
So
I mean, it's not a simple answer, but
Yeah.
like fibroids are an accelerated growth of the tissue that's in the uterus, which is muscle, right? The uterus contracts, right, for childbirth and pushing out babies, and so the fibroids are sort of discrete masses of that muscle. Most of the time, they're not cancerous because that's often what people think about when they hear the word tumor. The large majority of fibroids are not cancerous. They can be, but it's pretty rare. And same thing with cysts. Most of the time, they're going to be benign. That's the word we use when we're talking about when they're not malignant, but there also can be ones that are cancerous. And so, of course, we're not cancer specialists. So we're not the folks that are taking care of the women that have cancers of these structures, but we're dealing with the benign tumors, which are the fibroids, which cause heavy bleeding and pressure and pain, as well as, large cysts or masses on the tubes and fallopian tubes and ovaries.
All right, let's jump into endometriosis because it seems like it's a hot topic. Everybody's talking about it. I mean, I don't know if it's because social media has given women more of a voice, so they are talking more about what they've been going through. It could be a combination of the fact that it is technology and it's the fact that we're learning more about it, but like endometriosis has been talked a lot about. Same thing, like I feel like I have so many people that talk about ovarian cysts and fibroids, but endometriosis, for example, definitely has been talked a lot about. So it seems to take a long time to diagnose it. And so can you speak about the symptoms that what would somebody might think that they have it, and then how to go and kind of advocate yourself to get a test for it, and then like how do you test and diagnose it?
So this is one of the more interesting things that women struggle with. And oftentimes women sort of languish for years, sometimes decades, without really knowing what's going on until they finally get an adequate diagnosis. And part of the problem with endometriosis is the pain is truly severe. Like this is debilitating, life-altering pain that many women experience. But there's almost nothing that you can see on a CAT scan or an ultrasound or a blood test that proves that it's there. So that we're dealing now with decades and decades of almost medical gaslighting, where these women have tremendous pain. It leads them to seek care in the emergency room, and they're told, "Hey, your test is fine," and then they go home and say, "I'm in so much pain during my menstrual cycle." And they may have someone like a family member even say, "Well, my periods are painful too. They're just take some Motrin." They're missing an opportunity there to actually intervene. The clinical diagnosis of endometriosis is actually quite accurate. So if someone comes in, your gynecologist takes a thorough history, they'll be able to tell you with almost 90% accuracy that you have it. That is not, however, the gold standard, the way that we actually truly can diagnose it. So if you're a woman, you have chronic pelvic pain, and someone tells you, "Well, for your painful periods, I think you might have endometriosis. We're going to put you on some medical therapy." If it doesn't work, that's when, per your first question of the night, you might want to seek out someone who has a little bit more expertise in terms of the gold standard diagnosis, which is actually going in with a laparoscope, looking at the pelvis, taking some biopsies. And those treatments can not only definitively diagnose it, but also give us an opportunity to treat, and to treat early. So what we're trying to do, Dr. Green and I, is prevent the situation where someone has chronic pelvic pain and a suggested diagnosis of endometriosis, and they're 35 years old, and this has been going on since they're 15, and they've never had a surgery, they've never had a test that definitively said one way or another. And that is one of the more common things that we see. So if your mom and your daughter's periods are horrible, and your periods are horrible, and everything that they're trying isn't working, that's a good reason to have a consultation. It's daunting to consider surgery, but
Yeah.
if it's a surgery from which someone can get a clear answer and recover fast, go home the same day, it might be worth it in some of those situations.
Let's back up and explain what is endometriosis. Oh my God, can I not talk tonight? I mean, you think I don't talk for a living? Like,
Well, that's all.
endometriosis.
Yeah, so
Is it exactly?
So essentially, yeah. So this one we kind of do know what it is, right? So in terms of the origin of things like fibroids and some cysts, sometimes we struggle with it, but endometriosis truly is tissue that normally exists and lives in the inside lining of the uterus elsewhere, meaning elsewhere in the pelvis. It can be behind the uterus or next to the uterus or on the bladder or on the colon or on the surface of the ovaries or even up in your diaphragm or even more exotic places. But once that tissue that's designed to respond to estrogen and grow, and eventually as that estrogen is withdrawn, bleed, if it's somewhere else, like sitting on your bladder or sitting on your colon, it'll still do that. It'll still grow, it'll still bleed. But when it grows and bleeds inside your abdomen and not inside your uterus, it can cause tremendous pain. It can cause scarring. It can cause damage to surrounding structures. So that's what it is.
Well,
And there's a lot of theories in how it gets there.
Is it there since birth? Like, what causes it to go there?
No. So there's a lot of theories as to why that happens. Well, the leading theory is in some women, when they have a menstrual cycle, some of those cells escape through the ends of the fallopian tubes into the pelvis. And in some of those women, when those cells escape, rather than your body just absorbing them, they just settle in almost like seeds in a field and begin to grow. It's not everyone, but there is certainly a genetic predisposition. Moms with endometriosis are more likely to have daughters with endometriosis. If your sister has it, you're more likely to have it than if she doesn't. So this is a clue that sometimes we'll get that, if we just did the hysterectomy of a 54-year-old for endometriosis and her daughter comes in at 15, complaining of really painful periods, okay, I think I probably have the answer. And then we can do some interventions early on to slow development, to alleviate pain, to acquire diagnosis. So this is where there's a big opportunity for young women to avoid that really devastating experience of decades of not necessarily being believed, of being in a lot of pain and people not taking you seriously, and having a lot of therapies thrown at you that may or may not work.
Yeah. And so some of the symptoms could be obviously painful menstrual periods, chronic pain in the lower back and pelvis, pain during or after sex, painful bowel movements or pain when urinating during menstrual periods, infertility, and also might cause bowel movements or pain when urinating during menstrual period. No, diarrhea, constipation, bloating, nausea, especially during menstrual periods. And like I said, one of my best friends, she would always complain. I mean, we've been best friends since college, and we're like, oh, here we go. Like, she's and she has her period again. But like, you're right. Like, we just thought that and I would have cramps, but like now hearing stories of women, how like they literally like couldn't get out of bed. I was like, I feel like such an asshole that like, even I was like, just take some Advil and let's go. You know what I mean? Like, we got to go to the bar.
Yeah.
And, you know, and you really learn, but like, that's the thing, right? Is that like what you learn in medicine and how, and finally women are like, this doesn't feel normal. This isn't just a regular period, that it's so important. And so, and again, I try to learn too, because it's like, wow, you hear about endometriosis for so long. Like, what is it exactly? So when you get surgery for endometriosis, is the goal to take out those pieces that grow where it's not supposed to, I'm assuming.
Absolutely. I
Now,
think that's
yes.
one of the things
Grey's
that,
Anatomy surgery
yeah,
here.
I mean, that's a lot of these things change even since we have been in training, right? So, you know, in the past, people would make a clinical diagnosis, and still today, right? Who wants to walk into an office and say, you need surgery, right? So,
Right.
you know, there is you know, it is a reasonable thing. Let's say the classic picture is that I have painful periods, right? And then as those implants, as we'll call them, that, you know, seed themselves inside the abdomen, wherever organs they're related to are the symptoms that we're going to have, right? So you mentioned many different symptoms, right? Bladder symptoms, symptoms with moving the bowels, painful sex. So it all depends on where the implants are. And it's a massive inflammatory response, right? And so that's what causes the pain. That's what causes what we see surgically. Unfortunately, what we see surgically doesn't line up to necessarily what women experience. But now there's a shift that the surgical diagnosis of endometriosis is what is paramount. And not everybody feels comfortable doing that. So, yes, we want to excise it, which allows us to remove those inflamed areas or the scarring that can develop between the neighboring organs. But it also gives us the diagnosis, right? So that tissue is looked at under a lab, you know, in a lab, and it can tell us that it's the cells from the uterus, and that's how endometriosis is diagnosed. On the
And I
flip
think,
side, when
yeah.
people have that discussion in the office, it's a guess, right? And maybe the guess is right, but the surgical diagnosis allows us to diagnose and treat, you know, with the same modality.
And is it all eight? Like, could you not have endometriosis and all of a sudden you're 50 and you get it? Or do you have it from the time that you get your first period?
I mean, as you mentioned,
Your
it's
first
usually a
period,
chronic
that's
condition, but
pretty early.
we've all seen both,
Yeah.
right? I've seen both. I had a woman recently this year who never had painful periods. And, you know, we end up doing a surgery, and she had what we call stage 4 endometriosis, where everything was stuck in a really massive inflammatory response in the abdomen. So most commonly, it's that indolent, very long, chronic, you know, someone hasn't made the diagnosis, someone threw a birth control pill or some other medicine, you know, people ignore it, they continue their lives and they adapt. I mean, that's what women do, right? Whether it's bleeding or pain, they just kind of keep going until something happens, right? So either they hopefully see something like this where, you know, they see someone talking, or they have a family member, or they go to a hospital and maybe they connect with a provider that has a little bit more information, but often they're seeking, right?
Yeah.
Until some event happens and they're able to get a diagnosis.
But you would say, generally speaking, most women have this from the time that they get their first menstrual period.
Yeah, it's often very chronic. And unfortunately, the surgery does improve people, but it doesn't take away the condition, right? The condition does still exist. And those are things that we would have a discussion in the office about, like, how can we.
Some women have to get it multiple times, right?
Exactly.
Yeah.
I just don't want to mislead people to think that a single surgery makes a difference, but not makes a difference, but would be a cure, let's say. The process is still happening, but how can we manage that? And certainly surgery has been shown to improve quality of life. And often, sometimes people only do have a single surgery. I would say the younger they are, they probably have a chance of having to have something again in the future.
Yeah, an old coworker of mine had the surgery to get pregnant. She did in vitro, got pregnant, got the surgery again. And I'm like, what women have to go through? My God. Men are just, you know, peeing wherever they want, you know, what the hell? All right, so we're gonna do the Q&A in a minute, but before we do the Q&A, I want to know what you're most passionate about, what you do, and what drove you to become minimally invasive gynecological surgeon. So Dr. Bowers, you can go first.
Yeah.
Sure. So I always kind of go back to like why I was an OBGYN in the first place, because it's kind of an interesting thing. So when I started medical school, I started a little bit later in life. I had worked for a few years after college. And one of my best friends convinced me to go. And when I was in med school, I was like, I feel like I'm going to be a general surgeon or a trauma surgeon. And I did that rotation. It was somewhat appealing, but not terrific. And then I did family medicine, and it was very appealing, but not terrific. You don't really do a whole lot with your hands. And the last thing I thought I would do was be an OBGYN. It's just not a lot of men were going into it at the time. And
Yeah.
it really wasn't something that was on the radar. So I did my rotation, and I will tell you that even though neither of us do it anymore, delivering babies is a pretty incredible experience to be part of, right? That's astounding. But the other thing I learned in the rotation is that the surgery that is conducted on women can be so impactful because there are all these conditions that have to be treated with surgery. And when women do what Mina suggested they do, which is oftentimes they put it aside and put it aside and put it aside because they're taking care of their husband, their parents, their children, their job, their household. And that's the last thing they can do. When they finally do something, and we can offer them something when they're like, oh my God, I didn't believe you when you told me I would be back to work in 3 days, and I am. I didn't believe you when you told me I wouldn't have to take a lot of pain medication, and I can. I can do this without pain medication. I didn't believe you when you told me my incision was going to be this big, and it is, right? So
Yeah.
that's a very empowering thing when we go into something that, we're here to help people. Like, no one goes into medicine if you don't have some drive that you want to help people.
Yeah.
And when you tell them, I can help you and I can help you this way, and then afterwards they give you that validation, like, you know what, this really meant a lot to me. That's a huge thing as a person where that's a primary motivator. I will also say that I really like toys, right? And we get to play with robots and
Yeah.
laparoscopic instruments, and both Dr. Green and I get access to stuff really early because we both do a lot of volume. So that's the other sort of technical, really fun part. But I think that anyone who goes into any medical field, especially surgery, though, you're driven because you want to actively do something to fix something to make someone's life better. And I think that that's probably the most key element of it for me.
It's awesome. Dr. Green, what about you?
Yeah, I mean, I'm nodding because, it's
Yeah.
sort of, you feel all of those things. I'm a little bit different. I always often talk about I was a young mother, so I sort of had to draw as a patient myself and what that vulnerability feels like, that I wanted to help women. So I never went into OBGYN thinking that surgery was going to be it. I also loved surgery. I actually liked orthopedic surgery and trauma surgery as well. But there was something about the connection that was able to be made. And then I just, like many of us, was exposed to a mentor that really took me down that route, playing with the toys, as we say, going to national conferences and really being enlightened about what really is out there. And there's some innovative stuff. And half of the stuff we do, we weren't trained to do this in our training programs. It's really the stuff that comes to the forefront. And like Jeff said, like having access to it early and even sometimes participating in studies to see if some of this stuff is something that's going to stick. For me, I'm also a woman of color, and so it is my obligation as a woman of color to be able to be a face for people that look like me, who often don't have access or don't feel comfortable speaking up or don't trust their providers, to know that we are able to offer this to all women, not just certain women, but all women. And as Jeff mentioned, we're lucky that we're in a place that we have the ability to offer most things. Many places might have a single person that does this or a single provider that does that. And that's not any knock to them. It's just that we do have a very big armamentarium of things, whether it's being able to do procedures in the office, being able to do minimally invasive procedures where people are down from work and life much quicker than they expected. Really improving that quality of life. And even, we didn't mention, we have other colleagues, right? That we can collaborate with, which is our intestinal surgeons or our bladder surgeons, or people that we do often do concomitant procedures together, because many times maybe there is more than one issue and it doesn't impact more than one organ system. So we are very inspired by the effect that we can have. And certainly being able to offer that innovation, that excitement of what's new and what's fresh. And yes, it's super cool to operate with robots and instruments. Again, it's like watching that Phillies game today versus 20, 30 years ago. So it's
Yeah.
hugely exciting and rewarding.
Do we know the score, by the way? Does anybody
I
have
know.
Let us know the score in the chat while I go to the Q&A. All right, here we go. Question 1.
Great idea.
What is it? No, I don't know. Somebody will tell us the score in the chat. All right, so it is. Oh my God, it's 1-1. Jesus.
Ugh.
Oh my God, where are we? What inning? Okay, so 73 years old. I had a cervical soup. Is that right?
Cervical.
Cervical hysterectomy at 38. In the last year, I've been having hot flashes. What could be the cause? This definitely seems out of the normal for a 73-year-old.
So that's correct. I mean, most women, after they transition through menopause and experience those symptoms, or certainly after they go through a surgery, and some of it depends on whether or not the ovaries were removed at the time of the hysterectomy, but hot flashes should be around that time when you transition through menopause or at the time that your ovaries are removed. Now, they can last a long time, but if they go away and then come back, that might be something altogether different. And there are a lot of things that can cause symptoms similar to that. So it behooves you at that point to go to your provider and say, hey, listen, it's been 20 years since I had a hot flash. And the last year I've been having them every single day. Things like thyroid dysfunction or other endocrinologic conditions can mimic those symptoms and actually lead you to have things that are very reminiscent of menopause but aren't menopause. Even rarer, sometimes you can have tumors that secrete some of the hormones that women no longer have that could lead you to have some of those symptoms as well. So that's definitely a reason to seek care, get some blood work and some testing done. There are some things that are quite easy to treat. There are some things that are a little bit more esoteric and might take a little bit more digging. But anytime a symptom like that, after menopause, when those symptoms go away, there's not a lot of reasons why 20 years later they'll come back and not be a normal thing. So that insight is absolutely correct. That's not a normal experience and definitely should have a workup completed.
So this is just a shout out. It says, I'm grateful for these chats that Virtua provides. I attended one a year ago and it led me to a specialist that is helping me with pain due to menopause and stress. So yay, that's awesome. All right, what about uterine fibroids? Do treatments need surgery?
Actually, no. The answer is no. I kind of alluded to that. It's really becomes the issue of whether it's bothersome. So often those are going to be the symptoms that women complain of. So the two big categories for fibroids are going to be bleeding abnormalities and then what we call bulk symptoms, which is related to their size and their location. So what they're pushing on the other structures in the abdomen. So anything from pressure on the bladder to pain with intercourse as you're moving the bigger or enlarged uterus around to pain in the back. Pressure, those kinds of things. But then there also are women who can have more severe findings where maybe they didn't realize they had those symptoms because maybe they've had them for such a long time and it's kind of normal. We've seen women who, they can have a backup in their kidney system or swelling in their leg because it's pushing on, some of the major vessels in the pelvis. And those women are forced to do something, right? Because then it can negatively impact, other structures. So it's really if it's bothersome, right? So heavy bleeding, irregular bleeding, prolonged bleeding, those scenarios where, we can't wear white during our period, we're having accidents, we're putting towels on the bed, wearing diapers, all of those adaptive things that women do, absolutely not normal. And then on the flip side, really the pelvic pressure and bulk symptoms, those are the two big categories where women end up seeking care. If you don't have any of those, you don't necessarily, right? A little pea of a fibroid or a grape might not necessarily have to do something about.
Cool. What is a prolapsed uterus?
Well, when women talk about having a dropped bladder or having a dropped rectum or having a dropped uterus, essentially all those categories deal with what's called pelvic organ prolapse. And it's a failure of some of the support structures that actually hold everything up and hold everything in its normal physiologic space. And some of the risk factors that those things can happen, that a bladder or the uterus or the rectum could drop, have to do with your family history. So college, if you have a family history where women have had this before, like your mom had to have a surgery for you, you're more likely. Childbirth, especially vaginal childbirth with bigger kids, chronic cough, Other conditions that apply a lot of pressure downward to the pelvic floor can lead that to happen. Most women start to seek care for this when they feel something like a bulge outside of their body, where they feel a sensation of pressure, in particular when they're exercising, lifting up their children, doing anything that would actually lead to more of that pressure there. There's sometimes accompanying symptoms like urinary incontinence, difficulty moving your bowels, and pain with sex. Those can also accompany it. Now, fortunately, in particular in that realm, there's also a lot of techniques, both surgical and non-surgical, and the surgical techniques are almost all exclusively minimally invasive techniques where we can fix all of those things. This is a topic that got a lot of interest too because there were a lot of grafts involved, artificial grafts involved, that caused a lot of havoc when they were placed. I know that neither of us use those. And so there's techniques that don't require to use those things, and nor does anyone really at our institution use those grafts. So if you're withholding approaching getting care for something like that because you're scared that someone's going to put something in your body that might cause you harm, you don't have to feel that way. And you should certainly feel empowered to ask about those types of things too. But that's also not something that is normal. It's something that is common, but it should be intervened upon when it's bothering someone.
Yeah. What can be done about painful intercourse? I was like, wait, do I hear myself? What can be done by painful intercourse that is caused by a lack of activity for a number of years?
Well, so some of that probably is related to where a woman is in her lifespan, right? So as we mentioned, menopause is really that the ovaries stop making estrogen in large amounts. And estrogen does a lot of fabulous things for our bodies, one of which is lubricating the vagina. But often as we age, the tissue, sort of the integrity of it, the flexibility of it, the moisture of it, all of that changes with that transition as we talk about. And so not everybody experiences the same degree. But something as simple as using a lubricant may be enough for one woman. And on the other end of the spectrum, sex can be so painful that they can't even complete or even do the active sex. And so some of those women need, maybe it would be a topical estrogen therapy, or even something where if the vaginal vault was narrowed or from surgery or radiation, or sometimes pelvic floor physical therapy can help with women developing their core muscles, and then also sort of bringing back that vitality to the tissue that changes with menopause.
But it's a great question too, because, we've done a bunch of these for women's health. And I think a lot of women, especially probably women, maybe even over 60, a lot of the boomer generation, they weren't really told that like sex should be fun and pleasurable. It was almost like supposed to be like a chore. And like so many of these have been so great because it's like, we want to empower you. It doesn't, like 70's the new 50. You know what I mean? Like, go get it, ladies. If you're not feeling good, like talk to your doctor about it, because you should still be able to have a good time,
You should. And I think there's a lot of options, right? Everything's not going to work for everyone. And again, and some providers also, we don't even sometimes ask about sex. Like
Right.
Sexual history should be part of a gynecologic history. And I just think some of that is a culture shift from some of the generations prior to us. But
yeah, because there's all the
if we can ask questions, then we can kind of tease it out, and maybe either work on it ourselves or certainly refer to folks in our system that can help.
You see a lot of news studies now that there's all these like 55 and over communities that like have a lot of STDs because people are just like driving around in their golf carts, like beep, beep. So like, you should talk about your sexual health.
Yeah. Because they don't use protection because they can't get pregnant, right? So,
but there's other, so this is all, it's all important. It's all about like women's health, women's wellness. And even though you went through menopause, other things still could be happening. So it's good to talk about your sexual health, talk about your sexual history when you go see your gynecologist.
Absolutely.
Okay. So, in another chat, Dr. Kramer said, if you don't use it, you lose it. So there you go. I love it.
And you can use it alone. It's okay.
So the two quick statements. Thank you for this great information, women's health. And then Dr. Green is awesome. She provided me with the gift of experiencing a brand new life to live. My surgery was in June of 2023, and I'm doing great. I loved her bedside manner, excellent communication skills, minimal invasive approach to surgery. Most important, I felt 100% comfortable that she is a woman of color like myself. I was treated as a person, not just a number. Thank you. Oh my God, how nice is that? I love it. So before we wrap up, is there anything that you look at that made me tear up for some reason? So is there anything that both of you, is there one or two statements that you would like to, the people that are watching, the people that are going to see the recording, that you would really would like them to know moving forward about their health?
I mean, I think the message that we've kind of put out there throughout the whole thing is that if it doesn't feel normal, if it's affecting your life in a negative way, if it's impacting your job, your family, your relationships, and you don't feel like you're getting an answer, ask those questions. Ask those questions and advocate for yourself. You're right. This is a great era in terms of information for women. Like women, there's a lot of access out there. There's a lot more attention paid to the things that are affecting women. But you still will not watch the Super Bowl and see an ad where a woman comes on the screen and says, my periods are incredibly heavy. It'll never happen, right? Because those types of questions are not palatable questions that Americans are ready to hear, right? The greatest thing that I saw in the Super Bowl recently was Mary J. Blige getting a mammogram. Right?
Yeah.
I mean, this is like one of the first things that you like see. That was an ad in the Super Bowl, but it's the first time that women's health, that they actually expose something that women go through that's painful, uncomfortable, but necessary. And finally, they're putting it out there for the general public. This is something that, you're right, it's not just women in their 60s that like don't talk about sex. Women in general, in larger groups and larger communities, and certainly on television, they don't talk about periods. They don't talk about painless sex. They don't talk about discharge. They don't talk about infections. These are not things that people are quite ready to talk about on that type of forum. So women and providers, we have to be ready, right? We have to be ready. We have to, as Dr. Green said, we have to ask the appropriate questions to try to help as much as we can. But women of their own feel empowered and feel, supported to advocate for yourself if something doesn't feel right. And if you feel like you're not getting a good enough answer, ask questions to someone else. And no one should ever have their feelings hurt, or no one should ever feel disenfranchised. If you're like, I appreciate you taking the time to meet with me, I'm going to ask someone else the same questions. That's what we're here for.
How about you, Dr. Green?
Same. I mean, women, we have to be our own best advocate, right? So if you fail, try again. I mean, you don't have to be tied to a single person. And even there are different providers that come to us for different points in time, right? So we do surgery, and that doesn't mean you can't go back and see your primary gynecologist for your routine visits and care and discussions. It is our job, if there is a better therapy for a patient, to refer to a person that is able to offer that better therapy, right? So not every provider, has the ability to do everything. And so I think, listen to your body, right? You are your own best advocate because you know your body best, and seek answers and information. And you always are entitled to a second and third opinion. That is your right. When you mesh with a provider, then you take advantage of that. And certainly we all have networks of people too, right? If I don't have an answer for you, if I don't perform something in particular, then, I can send it to my partner or one of my colleagues. And so, that's the beauty of our field, is that we are able to help women, empower women to not feel ashamed. There's nothing to be ashamed of. There are many women that are experiencing all of these things. We just have to bring it to the forefront, both individually and then as a field, so women are more comfortable.
So, unfortunately, the Phillies lost 2-1.
Oh, ouch.
Damn it. Thank you. So, I know. So I don't know. Do you think they did it on purpose though, so they could come home and celebrate? Because I kind of think they did. I kind of think that they may have done. Same thing with the Eagles. I kind of think they may have threw the Jets game because they needed to protect their health for the Dolphins. I don't know. Not that I'm a conspiracy theorist, but like maybe they wanted to celebrate at home. All right. This was awesome. Thank you so much. And remember, it's your body. And if it's not functioning the way you want it, there is help. That's why Virtua is amazing, because there's so much as help. And a recording of this session will be emailed to you within the next week. And if you'd like to schedule an appointment with one of Virtua's minimally invasive listen to me talking today, gynecologists, call 856-325-4200. Thank you so much for joining us. Thank you, Dr. Bowers and Dr. Green, for another terrific Real Talk session. Have a great rest of your week. Go Phillies. Go Eagles.
Thank you, Nicole. Thank you,
guys. Appreciate it. Thank you so much.